Thank you, Dr. Purvi, for inviting me here. I'm not going to thank Manoj for a reason, I'll tell you that. So I'm in a crucial phase, contesting some election, very busy with campaigning. And at this time, I am given a very tough topic. I was not prepared with this topic. I requested him change my topic. I don't have slides, but he somehow made me study it. So today I'm in that phase where you come for a Viva unprepared. So I'm not very prepared with the topic. If there are questions, then Rakesh is there and Sukesh is there. They must have prepared very well for the debate. So we all know that SGLT2 inhibitors are the class of drugs which work on the SGLT2 receptors and basically prohibit the reabsorption of glucose from the tubules, leading to glucosuria. So this is the mechanism, and these are the drugs in this class that we have. And although the drug initially was intended to be used for treatment of diabetes, later on we found out that it has got many other benefits. In terms of metabolic effects, it leads to weight reduction, a modest reduction. Some visceral adiposity it addresses. It also improves the insulin sensitivity. It also has effects on the blood pressure. And then now with the long-term CVOT trials, we got to know that these are the drugs which are very good for heart. They reduce the risk of heart failure. They reduce the progression of CKD. And that is why these drugs are now being used by even cardiologists and nephrologists. This is the journey of all the different trials with the SGLT2 inhibitor class. So initially started with the indication for treatment of diabetes, and later on we had another indications which got added, like for patients of CVD, patients of heart failure with preserved ejection fraction, reduced ejection fraction, and even now for CKD, and now even for non-diabetic patients also these drugs are being used. And these are some studies which are basically looking at the patients with kidney disease over 40 years. Again, earlier we only had the ACE inhibitors, ARBs, which were there for preventing the progression of CKD, but now this drug also has the indication. It helps the patients for prevention of progression of the CKD. And in patients with in patients of cardiovascular disease, throughout the spectrum, this drug has been found to be useful. Whether the patient has just a risk of heart failure or the patients who are already having heart failure, these drugs can be used, and there are several studies. I'm not going through all these studies. So this is the outpatient story, which was also covered in the debate, that in the outpatient department, we know that these drugs are very good for treatment of diabetes and the other metabolic disorders like obesity, blood pressure will have some effect. Additionally, they have got these two major benefits, heart failure and CKD, and that is why these drugs are very popular and being used now. But what about the indoor patients? That is the topic that was given to me by Manoj. And we know that these indoor patients, they have a different physiology. They are having some acute illness because of which there is a higher levels of stress hormones, cortisol levels are high, insulin resistance is high. Some of these patients may not be eating well. That's why they are in the fasting state. And that is why these patients are at a risk of euglycemic ketoacidosis. Volume status is a concern. These drugs, we know that they cause diuresis, and the patients may not be having proper intake. And if we want to prevent the euglycemic ketoacidosis, we need to monitor for the ketones, and that monitoring is also complex. That is why there are several challenges of using these drugs for the patients who are hospitalized, and what is the status currently in different indications. So for patients who are indoor, we need to look at the risk-benefit balance and look at the clinical context. What is the reason for the admission of the patient? Is the usage of these drugs going to help us in some way, or it is going to be harmful? And even if you want to use it, are you having the capabilities to monitor the patient so as to be watchful about the development of ketoacidosis? And there are some several patient factors like the patient's comorbidities, reasons for admission, and physiological stability. So we need to look at these three aspects. We know that there are beneficial effects of SGLT2 inhibitors even in hospitalized patients. They will reduce the risk of heart failure by around 20%. The risk of AKI goes down by 24%. The anti-proBNP levels also go down with the use of these drugs. And these can be safe if you can use it with close monitoring and proper patients. But then there are potential challenges. If the patient is there perioperative setting, you will have the risk of euglycemic decay because the patient might be fasting, may not be hydrated well. The oral intake goes down, there might be hemodynamic instability. Active AKI, we of course will be avoiding these drugs. And it is not indicated to use these drugs purely for glycemic control. We know that there is no enough evidence of these drugs being very useful in glycemic control, at least in a hospital setting. So there we'll better go for a drug like insulin-based regimes or some other drugs that have got some evidence to use. This was a case study from a center in the UK where, because of these concerns about usage of SGLT2 inhibitors in indoor patients, the hospital had a policy of blanketly stopping SGLT2 inhibitors in all the patients who get admitted for any reason. So there was automatic suspension of uses of these drugs because of the concerns of ketosis, and there was no individualization of any patients. Because of this, there were some issues, and later on in the audit, it was found that the suspension of these drugs was inappropriate in many patients. The patients who were admitted for heart failure, patients who were stable, and patients who were having adequate oral intake, and it was given inappropriately to some patients. So this was the audit finding, and that is why they had to change their hospital policy also. Now, what are the studies of uses of these drugs in hospitalized patients? There was one study, I'm not showing it here, where it was used during COVID period for patients who are admitted with COVID. And the conclusion of the study was that there was no harm but no benefit. So it doesn't make any sense of using this drug in patients who are for COVID. Most of the papers that I could find in limited time that I already admitted to were on patients who are admitted for either MI or heart failure or any cardiac condition. So this is a meta-analysis recently published, and it is looking at the mortality across the spectrum of MI, and that's a meta-analysis of the different studies. So here they had around 26,000 individuals with post-MI status, and overall they looked at the benefits. So the hazard ratio is 0.79. There is clearly benefit which favors the users of SGLT2 inhibitors in terms of all-cause mortality in total for the whole cohort. And if you divide these into early users and late users, then again the benefits are there. So whether you use it earlier in course in the hospital itself before discharge, or you do it after discharge, the benefits are there. So the patients post MI, this drug should be used, of course, with caution. The second meta-analysis is about the studies where they looked at the patients who are admitted with acute heart failure, and the usage of this drug was again assessed. So on different fronts, if you look at here the first part, you can see that it favors again the usage of SGLT2 inhibitors, whether you look for all-cause mortality or heart failure hospitalizations, CV deaths, rehospitalizations, and overall combined effects of CV death and hospitalization for heart failure. This is a third meta-analysis. Here, again, they looked at the usage of these drugs in patients admitted for acute MI for cardiovascular outcomes. And here they compared the early usage and late usage. And then they found that on most of the fronts, the drug was found to be useful. So the outcomes were in favor of use of these drugs. But barring a few instances like this one, the cardiovascular mortality, non-fatal MI, there the benefits were not there. The diamond is in the center. So based on these, in many settings, the approach has now been changed. So if a patient is admitted in emergency for any reason, then first we should ask the patient whether the patient has already been taking these drugs before getting to the hospital. If the patient has already been on the drug, then document it that the patient is a user of SGLT2 inhibitors. And then the second question that should be addressed to is whether the patient is going for any surgery or any procedure. If yes, then better to withhold the drug till the time the patient is going through the procedure, and maybe after the procedure before discharge you can reintroduce the drug. If the patient is not going for any procedure, then you further evaluate the reason for his admission. Does the patient have any risk factor for developing the ketoacidosis or infection? Consider significant reduction in oral intake or alcohol use or UTI or catheterization. So these are the factors that you consider. If these factors, any of these factors is present, then you better withhold the drug and you give it only after the patient is stabilized, maybe at the time of discharge. If these factors are not there, then again you document these things, and if you are using the drug, then do monitoring for ketones on a frequent basis. So these are the factors that we need to keep in mind when you look at the risk of developing ketoacidosis in these patients. If the patient is going to be in a fasting state, NBM for any reasons, maybe for a surgery or for some other reason, if the patient is not eating well, if it's a perioperative period, if the patient is admitted with an acute illness, if the patient is a type 1 patient, again better to avoid the drug. If a patient is consuming alcohol, better to avoid the drug. So this is again a flow chart where if a patient is coming to you with an acute heart failure, then you look for the symptomatic hypotension or systolic blood pressure. If it is less than 100, then better to not start the drug. If the patient is using any vasodilator or inotropes, or there is increase in IV loop diuretic within the past 6 hours, better to withhold the drug. If the EGFR is very low, less than 25, again better to not start the drug. Otherwise, you can use these drugs earlier in the course of admission. And once you have started the drug, then you again keep monitoring the patient for development of ketosis. So this is the structured monitoring protocol. You should do the baseline assessment with serum ketones, renal function, electrolytes, hemodynamic status of the patient, hydration status of the patient. Then you do daily monitoring for ketones, daily weight and fluid balance, RFT, blood pressure, heart rate, any symptoms of decay. And you should withhold the drug if the patient develops positive ketones, if there is a decline in the EGFR more than 30%, if the systolic BP goes down to below 100, or the patient is nil by mouth for more than 24 hours, if the patient is posted for any major surgery that is requiring anesthesia. And at the time of discharge, then you educate the patient about the sick day management, tell the patient all the precautions that the patient needs to take while being on these drugs. So, in summary, for this clinical dilemma, we need to weigh both these things. What are the potential benefits? We know that the drugs will be helpful in reducing the risk of hospitalization for heart failure. It might reduce the risk of AKI. It improves the biomarkers. The hospital monitoring will be required for these patients, and you need to do a structured education for the patients. And there's a risk of euglycemic ketoacidosis, volume depletion, hemodynamic instability, and the efficacy in terms for glycemic control is not very good, and there is a burden for monitoring. So weighing these two things, we need to individualize these uses of the drugs for the patients who are hospitalized. So these are my key takeaways. If you have a patient who is hospitalized for these reasons, if the patient is coming for any cardiac event or maybe for heart failure, then better to use these drugs because there is evidence to show that these drugs have benefits. But if the patient is coming for some other reason, we don't have any reason to continue these drugs. We can withhold the drugs and maybe initiate those drugs at the time of discharge. So we need to individualize the approach for such patients. Heart failure patients, definitely use it. For other patients, you better avoid it and then follow structured protocol when you are using the drugs in the patients who are hospitalized. Thank you very much.